second aspect, as I said, was hyperandrogenism. And what would be the best thing to do? The best test to find out if there is hyperandrogenism is actually free testosterone, because as I said, SHBG being abnormal, you would often find that the total testosterone could be actually normal in many situations. The total testosterone therefore is often normal, and even if elevated, remember that it is not significantly elevated. It does not enter tumor range hyperandrogenism, and tumors are suspected typically if the testosterone starts crossing 1.5 nanograms per ml or more likely 2 nanograms per ml. Below that, you're probably dealing with production in the ovary and the adrenal. Now, these are the sources of androgens. Couple of things here. If you look at the various androgens that we do, commonest that we do is testosterone. And if you see here, ovary produces in a normal woman 60% of testosterone, 35% comes from the adrenal, and 5% comes from the periphery. Now, therefore, if you have elevated testosterone, some of it comes from ovary, some of it comes from adrenal. As I said, there is some degree of functional ovarian hyperandrogenism in these people as well. What about this test? This is a very favorite test with many people. That's DHEAS, or dihydroepiandrosterone sulfate. Now, as a rule, DHEAS primarily comes from the adrenal. So, if you want to see whether the adrenals are very severely involved, DHEAS might be a good test, and very large elevations of DHEAS are typically seen actually with adrenal tumors, and in some cases of congenital adrenal virilizing hyperplasia. So, DHEAS is more a marker of adrenal, testosterone is more a marker of ovary. DHT, which is again very commonly prescribed to be done as a test, neither comes from the ovary nor comes from the adrenal. It is just converted from testosterone to DHT in the periphery. So, doing a DHT alone actually doesn't tell you much. DHT comes from the 5-alpha reductase enzyme, and the entire testosterone load is converted into DHT. And androstenediol comes from the DHT. So, these are the further markers or further metabolites of testosterone. What I am trying to say is, if you want to see whether there is hyperandrogenism or not, a single testosterone value is also good enough. You don't need to do all of these to find out if there is hirsutism, if there is hyperandrogenism. And basically, if a girl has hair, she has hyperandrogenism, whatever the testosterone says. So, period. That really doesn't matter. So, the last few things about, I'm going to skip this, the testing. The tests that are done in PCOD, as I said in the beginning of my lecture, are not to prove PCOD, but to rule out the other disorders which look like PCOD. And this so-called FSH-LH, FSH is basically done to rule out hypothalamic amenorrhea and POF. So, you would have extremes of FSH in both these. Hypothalamic would produce with low FSH, POF will produce high FSH. Prolactin, please remember that mild prolactin elevations are very common in polycystic ovarian syndromes for a variety of reasons, and minor elevations do not mean anything. You may investigate further, as we discussed yesterday with pooled prolactin, etc., if prolactin is crossing 40, but sometimes elevations of up to 200 nanograms per ml are known in PCOD. You must do a thyroid test because, as I said, these things you need to rule out. IGF-1 to rule out acromegaly in certain cases, not all, if your facial features are the ones which I showed you earlier. Cortisol testing appropriate to rule out Cushing's, again, if there is a clinical suspicion of Cushing's. And of course, this is necessary. This rules out a late onset CH. So, your investigations, if at all you would do them, would be FSH, LH, prolactin, a simple testosterone, a 17-hydroxyprogesterone. Insulin levels are not required routinely because they don't necessarily add to anything. There are clinical markers of insulin resistance like acanthosis and acrocordons, but if done, you will often find them to be elevated in relation to blood sugars. But do not forget to do a glucose challenge, because type 2 diabetes is so common. Do not forget to do lipids, and do not forget to do SGPT, because there is a high incidence of NAFLD in this. Yeah, so I'll skip this. Okay, this is what many clinicians use, and this is called the Ferriman-Galway score. Not that you would require this, but when you're seeing patients in your lab, you know, these are the gradations. So they have hair on the lower chin, they have hair on the upper lip, they have it on the mammary areas and the central part of the chest, on the linea alba, the lower part of the abdomen, lower parts of the back, inner thighs. These are areas where normally girls wouldn't have hair. So hair on this part or on the legs are not sexual dependent hair, so we don't necessarily do anything about it. Now what hirsutism occurs actually, it's because of the interaction between the plasma androgens and the sensitivity of the hair follicle to androgens. So it's a complex interplay between these two. If the testosterone is high, it's a no-brainer. I mean, there will be hirsutism. But when the testosterone is normal, periods are normal, girls can still develop hair, and that is because these girls have a very heightened sensitivity of their pilosebaceous units to whatever circulating androgens are there inside the body. So it is called idiopathic hirsutism. We don't know what the cause really is. It is often genetic. So they are completely normal otherwise. The glucose is normal, lipids normal, liver is normal, they are not obese, they have normal cycles, but they have hair. And this could be because their hair follicles are responding in an exaggerated fashion to the circulating androgens. The most common causes of hirsutism, as I said, are of course PCOS, the first one. By definition, it is the first unless ruled out. And others are congenital adrenal hyperplasia, where the typical test would be 17 OHP, androgen producing tumors of adrenal ovary, which typically manifests as very high levels of testosterone, usually more than 200 nanograms per ml. Certain drugs like valproate produces exactly a syndrome looking like PCOD, and rarely hyperprolactinemia, Cushing's, and even more rarely, acromegaly can look like this. Now, what is the lab evaluation for hirsutism alone? Testing for elevated androgen levels in women with isolated mild hirsutism is probably not necessary, because the chances of identifying a major medical disorder that would change management or outcome is very low. These are Endocrine Society guidelines.